Welcome to the deep dive. Okay, so let's unpack this. Have you ever heard the term diverticulitis or maybe diverticulosis and felt a little fuzzy on what it actually means? You're definitely not alone. Today, we're going to dig into the world of diverticular disease, our mission. Cut through the confusion, clarify the jargon, and give you a really crystal clear understanding of these conditions. They're super common, but often well misunderstood.
Exactly. And what's fascinating here really is how often these terms get used almost interchangeably, like they mean the same thing. But understanding the precise differences, that can be incredibly empowering, whether it's just for your own knowledge or, maybe helping someone you care about navigate it.
Yeah, that distinction sounds crucial.
Yeah.
So let's start right at square one. When we talk about diverticular, what are we actually referring to? What are they?
Okay, imagine tiny, like sac-like pouches. And they protrude, they bulge outwards from the wall of a tube-like structure in your body, typically within the digestive tract. Think of them almost like little pockets. Or maybe small outpouchings. They tend to form where the wall might have a bit of a weak spot.
Like a little bulge on an inner tube?
Exactly like that. It's a good analogy. But here's a really key detail. Not all diverticula are created equal. We basically have two main types. True diverticula and false, or you might hear them called pseudo-diverticula.
Okay, so it's not just a generic pouch then. There's an actual difference in how they're built, their structure. That's interesting. What sets them apart?
Precisely. So a true diverticulum, this involves all the layers, every single layer of the digestive tract wall pushing outwards together. It's what we call a full thickness protrusion. The entire wall makes up that pouch. And the classic examples, you've got esophageal diverticula, which are in your food pipe, and then the really quite unique Meckel diverticulum. We should definitely circle back to Meckel's later. It's a fascinating one. Now, on the other hand, you have false or pseudodiverticula. These are a bit different. They happen when only the inner lining, that's the mucosa and submucosa, pushes through the outer muscular wall. It's like, imagine only the inner lining of that bicycle tube squeezing through a tiny hole in the outer tire. The outer muscle layer gets left behind, essentially.
I see.
And the type you're probably thinking of, the most common ones by far, are colonic diverticula. These are the ones that form in the large intestine, the colon, and they are pseudodiverticula.
Okay, got it. And just to be super clear, one is a diverticulum, singular.
Yeah.
And if you have more than one, it's diverticula, plural, little mini pockets.
Exactly right.
So now that we have this picture of these little pouches, what's really crucial to understand next, I think, is that just having them doesn't automatically mean you're sick, right? There's like a progression from just being there silently to potentially serious inflammation. Can you walk us through that spectrum?
Absolutely. That spectrum is key to understanding the whole picture. So first up, you have diverticulosis. This term simply means the presence of one or more diverticulates, the fact that these pouches exist. And here's a really important point. It's very often completely asymptomatic.
Meaning no symptoms at all?
None at all. Many, many people have diverticulosis. They walk around with it and never even know it exists. It causes them zero issues.
Okay, next along this spectrum is diverticular disease. Now, this is the point where that diverticulosis becomes symptomatic. So you have the pouches, right? But now those pouches are actually causing symptoms. Things like abdominal discomfort, maybe bloating, changes in bowel habits like constipation or diarrhea. But importantly, this is without acute inflammation.
So discomfort, but not necessarily an infection yet. Exactly. The symptoms can sometimes be a bit vague, too, and overlap with other digestive issues, which can make it tricky. And then finally, we get to diverticulitis. This is the most acute stage we talk about. It involves actual inflammation of a diverticulum, and that inflammation might or might not involve an active infection. Now, diverticulitis, this is where things can get more serious. It can lead to complications like a bowel wall phlegmon, which is basically an inflammatory mass, or peritonitis. That's inflammation of the lining of your abdomen. It could even lead to a perforation, which is a hole in the bowel wall, or an abscess, or a fistula. It's definitely a significant step up from just having the pouches.
That breakdown is incredibly helpful. So maybe the single most important thing for you listening is don't mix up the often silent diverticulosis with the potentially urgent diverticulitis. Getting that difference is like your superpower here.
That's a great way to put it. That fundamental understanding is key.
How common are these conditions, especially the colonic ones you mentioned?
Oh, colonic diverticular are very, very common. Especially if people get older, the chances of having them really increase quite a bit after age 50. But it's also helpful to know that even though many people have these pouches, Only a relatively small percentage of those with diverticulosis actually go on to develop diverticulitis, that inflamed stage.
Okay.
And for those who do get diverticulitis, recurrences can happen, sure, but it's definitely not guaranteed. Maybe about 8% might have another episode within 10 years based on some studies. We also see some interesting patterns in who gets it, like diverticulitis in the lower part of the colon seems a bit more common in women overall, but in people under 50, it actually seems more common among white individuals. Interesting variations.
It's clear they're common, yeah. But it sounds like where these pouches pop up might be just as important as if you have them at all. Tell us more about that. How does the location change things? Each spot seems to have its own quirks.
Absolutely. Location is huge. It really dictates a lot about their characteristics and the potential issues they might cause. So let's start with colonic diverticula, again, most common, pseudo-diverticula, as we said. Now, here's something I really want to tackle head on because it's such a common myth. For years, people were told to avoid nuts, seeds, corn, popcorn if they had diverticulosis, right?
Oh, yeah, I definitely heard that.
Well, listen to this. Study after study has found no association, zero link, between eating those things and actually developing diverticulitis.
Seriously. So the popcorn is back on the menu.
Back on the menu. Enjoy those snacks. It's a myth we really need to bust.
That's fantastic news.
But on the flip side, things that do seem to help are being physically active and eating a diet high in fiber. Those are strongly suggested to help prevent the pouches from forming in the first place.
Good to know. Prevention is always better. Okay, so that's the colon. What about other, maybe less common locations?
Right, so next we have small bowel diverticula. Much less common than in the colon, but they can show up in the different parts of the small intestine, the duodenum, the jejunum, or the ileum. Duodenal ones, right at the beginning of the small intestine, are actually pretty common. Maybe 22% of people have them, but they're usually asymptomatic, cause no trouble.
Okay.
Jejunal and ileal diverticula further down are rarer, and when they do occur, they're often multiple pouches, not just one. What's unique about these small bowel ones are their potential complications. Yes, they can bleed or perforate like colonic ones, but they can also lead to chronic problems like diarrhea and, significantly, malabsorption.
Malabsorption, like not getting nutrients properly. How does that happen?
Exactly. It's often because bacteria can sort of overgrow within these pouches in the small bowel. This bacterial overgrowth then interferes with how your body normally absorbs nutrients from food. It's a distinct problem mainly seen with these small bowel types.
Wow, okay. And then there's the one you mentioned earlier, the Meckel diverticulum. You said it was unique. What's the story there?
Ugh. Meckles. It really is in a class of its own. So remember how colonic diverticula are false or pseudo? Meckles is a true diverticulum. All layers of the wall are involved. It's a congenital anomaly. That means you're born with it. It happens in about 2% of people, so not incredibly rare. It's basically leftover tissue from fetal development, from something called the vitelline duct not closing up completely.
Born with it.
But here's the really critical part. Meckel's diverticulum often contains ectopic tissue.
Ectopic, meaning tissue that shouldn't be there.
Precisely. Tissue that belongs somewhere else. Most commonly, it's gastric tissue stomach lining, or sometimes pancreatic tissue. Now, if it contains that stomach lining, that tissue can actually secrete acid, just like your stomach does. And that acid in the wrong place, like the small intestine, can cause ulcers nearby. And that leads to its classic symptom, especially in children: painless rectal bleeding. Bright red blood, no pain. In adults, it's a bit different. It often presents in a way that mimics appendicitis, causing pain or sometimes a bowel obstruction. Very different presentation.
That ectopic tissue explains a lot. Okay, so let's bring this back to the listener. What does this all mean for you? How would you know if you, or maybe someone you know, might be experiencing symptoms related to any of these conditions? What are the key signs?
Well, the first thing to stress again is that many people with diverticula, especially colonic ones, have no symptoms. Maybe 80% are completely asymptomatic.
Right.
But for those who do get symptoms, but without that acute inflammation we call diverticulitis, we sometimes use the term symptomatic uncomplicated diverticular disease, or SCAD. And the symptoms here are things like maybe nagging abdominal pain, bloating, constipation, sometimes diarrhea, maybe passing mucus from the rectum. The tricky part is these can can be kind of nonspecific, right? Could be other things too.
Sure, IBS, other things.
Exactly. Now, when it progresses to actual colonic diverticulitis, the inflammation, the symptoms usually become more distinct. The classic sign is left lower quadrant abdominal pain, often quite localized tenderness there, and that's frequently accompanied by fever, nausea, maybe vomiting. Though interestingly, as I mentioned, in some Asian populations, the pain might actually be on the right side, something to keep in mind.
Okay, left side pain is the classic clue for most, though.
Generally, yes. And for the meckel diverticulum, again, think painless rectal bleeding in kids. That's the big one. In adults, think abdominal pain that feels a lot like appendicitis or maybe signs of a bowel blockage.
It definitely sounds like the complications can range from uncomfortable to really quite serious. Can you maybe outline the most significant ones? Grouping them might help us grasp the range.
Absolutely. They can be serious, so awareness is key. We can group them into a few main categories. First, let's talk about bleeding. This can be a major issue. Colonic diverticula are actually a really common cause of lower GI bleeding, maybe up to half of significant cases. It typically presents as painless, bright red blood per rectum. We call that hematochezia.
Just blood, no pain.
Often, yes. Meckel's diverticulum, especially with that ectopic stomach tissue, is also a well-known cause of bleeding, particularly in younger people. Okay, second category. Infection-related complications, which we mostly see with diverticulitis. This is where things like perforation come in that hole in the bowel wall. That's an emergency. It can lead to peritonitis, a widespread abdominal infection. You can also get abscesses, which are walled-off collections of pus near the inflamed diverticulum, or fistulas, which are these abnormal tunnels that can form, say, between the colon and the bladder or the colon and the skin. Not good.
Yeah, definitely not.
Then third, you can have issues like obstruction, where the inflammation or scarring blocks the bowel passage. Or, as we discussed with small bowel diverticula specifically, that problem of malabsorption due to bacterial overgrowth. And one more specific one for the colon is segmental colitis associated with diverticulosis, or SCAD. It's another type of inflammation linked to the presence of diverticula.
That's quite a list.
It is. And it really highlights the importance of distinguishing between uncomplicated diverticulitis, which is mostly just inflammation, and thankfully the most common type, versus complicated diverticulitis. Complicated means one of those more serious things is happening. An abscess, a fistula, an obstruction, or a free perforation into the abdomen. Maybe about 12% of people presenting with diverticulitis initially have a complicated case.
That distinction seems vital for treatment, too. So if you suspect something's up, how do doctors actually figure out what's going on? What's the diagnostic deep dive look like? And then what are the options for managing it?
Right, diagnosis. If acute diverticulitis is the main concern, the go-to test is usually a CT scan of the abdomen and pelvis. It's really good at showing the inflammation, any potential complications like abscesses, and it's highly accurate, like 95–96% sensitive.
CT scan is key then.
It's generally the preferred first step in that acute setting. Ultrasound can also be used sometimes. Now, here's a really important point about colonoscopy that often causes confusion. You generally do not want to do a colonoscopy during an acute diverticulitis flare-up. There's a risk of making things worse, even causing a perforation because the bowel wall is inflamed and fragile.
Okay, so no scope during the attack.
Correct. However, a colonoscopy is usually recommended after the acute episode has completely settled down, maybe 1 to 3 months later. The purpose then is different. It's to get a good look at the whole colon, make sure there isn't anything else going on, like polyps or even ruling out cancer, which can sometimes mimic diverticulitis symptoms.
That makes sense. Check afterwards, not during.
Exactly. And just quickly, for that specific case of bleeding from a suspected Meckel diverticulum, there's a special nuclear medicine scan, the TC 99-meter pertechnetate scan, which is designed to light up that ectopic stomach tissue.
Got it. Okay, so once you have a diagnosis, how is it treated? It sounds like it could range from do nothing to major surgery.
That's absolutely right. Treatment is very much tailored to the specific situation, what type of diverticular issue it is, and how severe it is. So let's start with that basic question. What if you just have the pouches, asymptomatic diverticulosis, and no symptoms? What do you do?
Yeah, what's the advice there?
Simple. No specific treatment is needed. You just live your life. And again, absolutely no need to avoid nuts, seeds, corn, or popcorn. That advice is outdated. A high-fiber diet is generally good for colon health, but no specific diverticulosis diet is required if you feel fine.
Okay, easy enough. What about when it flares up? Acute, uncomplicated diverticulitis.
Right, the more common scenario. Just inflammation, no major complications. Often this can be managed conservatively, sometimes even at home. It usually involves bowel rest, starting with a clear liquid diet for a few days to give the colon a break. And often, antibiotics are prescribed to cover the common gut bacteria that might be involved. Things like metronidazole combined with another agent, or maybe amoxicillin clavulinate. The decision on whether to use antibiotics and which ones depends on the specific case and the doctor's judgment. Some very mild cases might even resolve without them.
So rest the gut, maybe antibiotics. What if it's complicated diverticulitis? Abscesses, perforation.
Now, the approach gets more serious, naturally. If there's an abscess, a small one, say less than 3 centimeters, might still respond just to IV antibiotics in the hospital. But larger abscesses usually require drainage. This is often done using CT-guided percutaneous drainage, where a radiologist uses the CT scan to guide a needle and drain the pus collection without open surgery. Surgery, however, becomes necessary for the really serious stuff, definitely for a perforation with peritonitis. Also needed if symptoms just won't settle despite medical treatment, or if someone has recurring episodes, especially recurring complicated diverticulitis. The surgery typically involves removing the diseased segment of the colon, often the sigmoid colon.
And what about the Meckel's diverticulum if it's causing problems?
For a symptomatic Meckel diverticulum, whether it's causing bleeding or inflammation, the treatment is almost always surgical resection. You need to remove the diverticulum itself mainly because of that risk of ongoing or recurrent bleeding from the ectopic tissue inside it. Surgery is usually curative for Meckel's.
Wow, what a journey through these conditions. It really strikes me how much more there is to it than just hearing diverticulitis.
Yeah.
From understanding the actual structure, these tiny variations in the pouches, to seeing that whole spectrum from totally silent to potentially very serious complications. It really drives home that precision and understanding what's actually going on matters hugely. It's definitely not just a generic tummy ache.
Absolutely. And if we kind of zoom out, connect this to the bigger picture, it's a great reminder that symptoms are really just clues, right?
Yeah.
And truly understanding the specific type of diverticular disease someone has. Is it simple diverticulosis? Is it SUVD? Is it uncomplicated diverticulitis or complicated? Is it colonic or small bowel or Meckel's? Knowing that specific diagnosis profoundly impacts how it's investigated and managed. It really makes you think, how often do we maybe generalize medical terms in everyday life without fully grasping the nuances? Those nuances are what define the right care pathway for each individual patient. Knowing these distinctions really empowers you, the listener, to understand your own health, or maybe help a loved one with much greater clarity.
That's a powerful thought. Definitely something to mull on. Thanks so much for walking us through all that complexity today. And thanks to all of you for joining us on this deep dive. Stay curious, stay informed, and we'll catch you next time.